the NAC's third virtual meeting. I'd like to remind everyone that this event is being recorded and will be posted on AHRQ's website once available. Also note that closed captioning is available for this meeting. If you look down at the bottom of the Zoom, there is an option that you can click on for closed captioning. I'd like to remind NAC members that if they would like to make a comment or ask a question during the meeting, to please write, "I have a question" or "I have a comment" in the chat box to all panelists. We're asking that you please don't post your question, just let us know you have a question and we will get to you. You can, we have all the panelists unmuted, but we would appreciate if you could mute your lines when you're not speaking. Let's see, I would like to remind NAC, members to mute your phone lines. Also, you can change your video settings. We encourage NAC members to use their videos if possible. We'd love to see you and it helps engage with the conversation. And you can also see all members at the same time. If you go to your video settings, there's an option that allows you to see 49 people at one time. So if you want to see all the NAC members in one view, you can go down there and select that option. If you are a non-NAC member and you would like to make a public comment during today's meeting, please send an email. Let's see. Oh, can we please, sorry, can we have the next slide, please? There we go. Okay, so let me, I am Tina Hernandez-Boussard. I am the NAC chair. And can we have the next slide, please? There we go. So if you're a non-NAC member and would like to make a public comment during today's meeting, we ask you to please send an email no later than 12 noon Eastern Standard Time to the email address on the slide, the National Advisory Council at ahrq.hhs.gov. Again, no later than 12 noon. And comments should be limited to 3 minutes each. Next slide, please. We have some updates to our NAC members. As shown here on this slide, Melinda Bunton's first meeting is this morning, so we are excited to have her here at our NAC meeting. The other two members updates you see here are job changes. So MI Pham has a new job title, and Ram is a former senior advisor, president, and community health investor officer at Northwell Health. Next slide, please. So I would like to call our first order of business this morning. I would like to ask if there are any changes or edits to draft the minutes from the meeting on March 26, 2020. If there are none, I would like to ask for a motion to approve the minutes.
So moved.
Thank you. Can I have a second? Thank you so much. Okay, we'll ask you to please sign a copy and mail those directly to Jamie. Now we're going to start the fun part of our meeting. We're going to get into our speakers. So first, I would like to introduce Mr. Gopal Khanna and David Myers for AHRQ's recent accomplishments.
Thank you, Tina. Good morning and welcome to our second virtual National Advisory Council meeting. I recognize that many of you have been extremely busy helping your local communities respond to the COVID-19 crisis. So let me say that I'm deeply, deeply appreciative of everyone's time today, and I hope to have an extremely productive discussion. Of course, a special thank you to our NAC chair, Dr. Tina Hernandez-Bouchard, for kicking off the meeting and for helping us formulate our topics for today's discussions. And another special thank you to our Deputy Director, Dr. David Myers, as well as Bob McNellis and Jamie Zimmerman, all of whom we will hear from later today. As you go through today's meeting, I would like us to focus on one important theme, defining AHRQ's role in responding to COVID-19 crisis. We have seen time and again the tremendous impact of AHRQ's work, but that message has not always rung loud and clear. We as an agency and as a NAC need to be diligent about heralding the benefits of our work, especially at a time when research for safe and effective care is so desperately needed. The consequences of the COVID-19 crisis cannot be understated. Global leaders have compared the pandemic to one of the worst tragedies in history. The impact of this health crisis will have long-lasting implications on the way healthcare is delivered in the United States and throughout the world. Never before has the importance of AHRQ's work been more readily apparent. As an agency, we have been directed by Congress to be a driving force of safe and effective 21st century care. However, the COVID-19 crisis has exposed major inadequacies in our healthcare continuum, demanding new research and new evidence to help healthcare providers save lives. In much the same way that financial crisis of 2008 exposed glaring holes in our financial structures, COVID-19 has exposed major gaps in our healthcare systems that AHRQ is poised to address. Recently, AHRQ staff has worked to define our role in several key areas of need, which you will hear from in more detail from David and Bob. But before they speak, I would like to take a moment to share these proposals from my perspective. At our core, we are the Better Outcomes Agency. We create evidence where it is lacking and work with providers to bring that evidence into practice. In that respect, there is so much work to be done for COVID-19. For instance, the COVID-19 crisis has highlighted a number of alarming disparities among different priority populations, and evidence is needed to understand how to best address the root causes of these differences. Likewise, I would say that evidence is needed to understand the nation's response and outcomes across different care settings, with nursing homes and long-term care facilities emerging as particular areas of need. We've also seen a rapid expansion in the use of telehealth services, requiring new evidence to understand what works and what doesn't, to equip policymakers with information they need to make long-term policy decisions. And of course, as federal, state, and local policymakers have raised to provide resources where COVID-19 has surged, we've discovered a tremendous need for a new supply-side database to help optimize resource allocation. And finally, along with this data, we need to rethink care management through a systems engineering approach to make the healthcare system as efficient as possible. Again, you will hear more details about these proposals in the presentations to come. But ultimately, we want your feedback and your buy-in as well, so that you can be champions of this work in your communities. As the foremost experts in your fields, you understand the importance of AHRQ's work. But you must never forget that in many ways, we are in a bubble, and not everyone understands the complexity of what we do. So as you listen in, think about how we can market ourselves and amplify our message in a way that resonates with the average American. As experts, each of you know how important this work is, but it is up to you to use your expertise to help us drive that message home. Again, we have a packed agenda today. First, we will hear from David Myers and Bob McNellis about AHRQ accomplishments and for an AHRQ COVID-19 update. Then at 11:35, we will have a 10-minute break. We will reconvene at about 11:45 to hear Jamie Zimmerman and David Myers to discuss the results of a study on health services research across the federal enterprise. And finally, we will turn it back over to Tina at 12:45 for the NAC Chair's wrap-up. With that, I look forward to a productive and important meeting. And now I'll turn it over to David. David, please.
Thanks. Thank you, Gopal. And again, for those who are having difficulty hearing, here's our agenda. Let's move forward to the next slide, please. I'm David Myers. I get to serve as Mr. Khanna's Deputy Director of the agency, formerly our Chief Medical Officer or Chief Physician, which is a perfect time for me to remind all of you that that position is currently being, we are actively recruiting for that. And I'll give a shout out to Andy, who's on the call with us today. He found a peer who he thought would enjoy working at AHRQ, and we've already had a series of great conversations with that person. But we're looking for more people to share the work, share AHRQ's work with, explain to them what we're doing and what we're looking for in a chief position. The position, Jamie and the team have shared it with you, but if you have any questions or think you know of somebody that you want us to reach out to, please let us know. We'd love to do that. Moving forward on the slides, the first thing before we dive into AHRQ's accomplishments, next slide, please, is, whoops, okay. I will update. This is not exactly the right slide, but it has been updated, which is exciting. We wanted to keep the NAC involved in our budget process, letting you know where we are in the funding cycle. The good news for us is that the House Appropriations Subcommittee of the Labor, Education, and AHHS Appropriations Committee recommended AHRQ receive $334 million in fiscal year 2021. That was a $5 million increase over what the government gave to us or Congress gave to us in FY 2020. So in these difficult times, any budget increase is actually a great show of support. And it's also impressive that this is an $87 million increase over the president's proposed budget, excuse me, for NERS, the National Institute for Research on Safety and Quality, which is the administration's plan for merging AHRQ with NIH. The House did not support that move and has once again requested that AHRQ remain a separate agency with a slight budget increase. Last night, before these slides went to bed, or as these slides were going to bed, the House Appropriations Subcommittee voted on the bill and as an entire package as well, and moved it forward to the full House for vote later this week, which is exciting. People will ask, where is the Senate? That is a very fair question. They have said they are not planning to move on the fiscal bills for 21 until after Labor Day. So we'll have to see what their thinking is about for AHRQ. Traditionally, they have a smaller starting level for Health and Human Services. So it will not be surprising if they propose slightly less than the House did. And that process, if it naturally worked itself out, they would go to a committee eventually and give us a budget. There is, of course, the possibility that this, in an election year, they will choose to go to a continuing resolution and keep the government funded through that. But we'll have to see. The other thing we wanted to let you know is that we're hearing that there are plans for a new COVID-related supplement to invest in America in addressing the COVID crisis. And we hope there'll be opportunities in that bill for AHRQ to continue our work. And we'll be having a discussion about that moving forward. Before I move into our accomplishment sections, are there any questions from the NAC members? Looking at the chat box, I don't see anything. Jamie, you agree? Tina, anything? Okay. I'm going to move on my slide set first. So actually, this is one of my favorite parts of working at AHRQ, learning about all the interesting efforts and accomplishments of my colleagues. And I'll admit to you, it's often hard to keep up with them. The breadth and the innovation of their work is just so impressive. And as NAC members, I imagine it can be equally challenging, if not more challenging, for you to wrap your heads around and incorporate all of AHRQ does into your own thinking. But I really believe it is critically important that you share with us this expansive view of AHRQ does, so as you're giving us guidance, and as you're our deputies speaking out in the community about what AHRQ is and what it should be and what it can be, that you have that full breadth. And that's why we take time at each of our meetings to share with you a sampling of the agency's achievement. Now, by necessity, I'm going to have to go through these very, very quickly. There's just way too much that our staff has packed into these slides for me today. I'm going to encourage you not to get stuck on the details. There are going to be some things you're going to say, wait, I want to know more about that. That means I've done my job right. If you would like at any point, any NAC member, to learn more about an area of AHRQ's work or any of the specific projects you hear today, I encourage you to reach out to Jamie or to me directly, and we'll set up a briefing for you and the subject matter experts at AHRQ to teach you and to engage with you in a discussion about our work. So with that as background, I'm going to give you this is my mental model of how I organize AHRQ's work. I think about it in our core competencies, the way we accomplish our work, through research, through improvement activities, through data and analytics, and of course, as an agency, we're committed to operational excellence. So I'll share some highlights in each of these sections. Next slide, please. So in the area of health systems research, I actually had to take out two major examples because Jamie is going to talk to you more later this afternoon about health services research and a study that we recently completed on the future of HSR, which I really think would have fit in this area. And then Bob McNellis is going to talk to you about our work in COVID-19, and I think that's where some of our most exciting research has been. That said, there are still plenty of great things to share with you today. So let me go with a few of those. Next slide, please. This is an example of work where AHRQ invested in a 5-year initiative called CHIPS, the Comparative Health Systems Performance Initiative, and realized that the amount of data that our research colleagues created could be reused by other teams around the country. And so we worked with them, and they are now in the process of making their data sets available to power future health services research about how the health system in the United States is organized, and how evidence is used by systems in practice. So our colleagues at Dartmouth are putting out a whole series of data sets that they learned about hospitals, emergency rooms, and nursing homes. Similarly, folks at the National Economics Research Center are putting out their databases, which have micro-survey level data about how hospitals are organized. And AHRQ ourselves has built the Compendium of U.S. Health Systems that look at how hospitals, doctors, and ambulatory practices are organized into systems, identifying almost 700 systems across the U.S. We recently updated that through 2018 and made that publicly available. The teams doing this work got together and were actually thinking about COVID and what their data told them about the organization of U.S. healthcare, and they put out a thought-provoking thought piece that was recently published, or actually earlier this spring published in Health Affairs, looking at how we might as a country organize nursing home care in a new way in a pandemic. Really thought-provoking and data-driven policymaking. Next slide, please. AHRQ continues our work in partnership with the CDC to understand and help clinicians and healthcare professionals deal with the dual problems of pain control and opioid addiction. Several years ago, the CDC published their first set of recommendations. They partnered with AHRQ to create a series of 3 evidence reports that will help the nation develop new clinical guidelines in the coming months. And those focus on how opioids do and are not effective for the treatment of chronic pain, things other than opioids for the treatment of chronic pain, and what is the evidence for those modalities, both medically and non-medically. Next slide, please. This is sort of a complex slide, and I hope folks will come back and look at it later. But it has to do with a combined effort funded partially through the department's work from the PCOR Trust Fund to build infrastructure for research. But what AHRQ brought to the table is the need to move to systems where the creation of clinical data is merged with the creation of research data in a seamless way. And that when patient care is driven by measures, or that measures are collected through the delivery of clinical care that improve care, those measures, if made available for research, will move forward and answer and ask better questions in research. And so this was a pilot project that you're seeing here, looking at depression care and saying, could we have a common set of measures in the care of depression that would lead to better clinical care that would help patients and doctors make better decisions, but also then make that data available for study and research. So a series of projects that built a framework for research and clinical care measures in depression care, and this is now actually being tested using sites with the American Academy of Family Medicine as well as the American Psychiatric Association. So really, really, I think, forward-thinking work. Next slide. Our evidence-based practice center, which we've talked about and how they're helping the CDC and drive clinical decision-making in the United States based on evidence. Also, it partners with our colleagues with CMS to help insurance decisions be based on evidence. And we have a long-standing partnership with CMS to do evidence reviews that are helped or are the foundations for national clinical coverage decisions. And here are several examples that have been worked on and are moving forward at the present time. Next slide. Final thing in research, again, using our EPC program, but in a very different way. This program is a partnership with the National Academies of Science, Engineering, and Medicine, as well as the National Institute on Aging, to look at the research agenda around care for people living with dementia. And the AHRQ evidence report was influenced by the questions being asked by the research community. AHRQ created the report and presented it to them, both the community of patients and caregivers as well as the researchers. And the report will then be finalized based on their feedback, fed back to the National Academy of Medicine. And their final report will come out this winter, but will be based on, again, AHRQ's evidence review. So we've shown you examples of how AHRQ, as the evidence and outcomes agency, is here working with our colleagues at CMS, our colleagues in the research community, and here in the clinical community to set the research agenda for the future. Next slide. Thinking about practice improvement, and I apologize, I get so excited by this stuff, I'm going into way too much detail, so Jamie, yell at me if we're gonna run out of time.
Yeah,
or
keep
Tina,
going.
Please. Feel free to do that as well. So let's talk in practice improvement. Okay, yeah, we're going to move a little bit faster. Next slide, please. In practice improvement, one of our exciting projects was called PRISM. We have colleagues here at the NAC who actually tested this modality at their health centers, health systems, but this is the idea that patient-reported outcomes can improve the delivery of clinical care, and how to make it easy both for patients to report and clinical teams to receive the information in ways that work best for both of them. Really nice project. Moving forward, next slide. The AHRQ continues to provide scientific and technical support to the Independent United States Preventive Services Task Force. They've been very busy even during the pandemic. Two very important reports that they published since the last time you all met. One was a new recommendation on screening for unhealthy drug use. And because of advances in the field and new evidence, they were able to actually create a positive recommendation for screening in primary care practice for adults. That was the one published in June. Unfortunately, at the same time they looked at the evidence, they discovered that for younger adults, teens, and adolescents, there's not yet evidence about what primary care can do to help stop drug abuse before it starts. So they put out a big call, an important call for more research in that field. Next slide. We've briefed you many times on AHRQ's focus on improving diagnosis. Our team in CQIPS is moving full steam ahead on multiple fronts, including research and practice improvement, and this is an example of partnering with health systems to help them understand the problem of improving diagnosis, and how they can use their own internal data to measure and get a handle on how diagnosis is in their system. Next slide, please. A final project, we've told you about this one before in our research section. The 6 building blocks came out of work from Michael Parchman and a group in Seattle about helping rural primary care practices with few resources better manage both pain and opioid use in their practice. AHRQ was so impressed by this, we partnered with them to develop it into a toolkit, which you can see here, which we recently published, and are now moving forward to testing this not only in rural practices, but more urban practices to understand better how this tool can be adapted and spread. So another part of our work in addressing the opioids crisis in a systematic way. Next slide, please. Thinking about data and analytics, next slide. We are always proud of our work with HCUP. They have been doing work to make sure that their data is available and easily usable and kept up to date. They have their fast stat pathways, which are ways that people can see data at a national and a state level, sort of pre-digested visual formats that make information from HCUP accessible to more people. You can see all these different ways that they are moving that data forward. Next slide, please. Our colleagues at MEPS, in addition to doing a lot of important work around COVID, here's an example of their work in the opioid space. The top bar shows you how spending in prescriptions overall is divided in the country. The bottom bar shows you how it's being used for opioids, and what jumps out very quickly is that Medicare pays for a lot of opioids, a higher percent than they do overall, which reminds us that the opioid crisis is not something that is only happening to young adults, it's also happening to older adults, which ties back into a new research initiative AHRQ is doing, and will be, in fact, funding the grants tomorrow, I hope, on helping healthcare systems treat pain appropriately in older adults, but recognizing the potential problems of overuse of opioids in older adults. The other bar that's slightly larger is yellow, reminding us that the uninsured and people even with insurance spend more to purchase their opioids than they do the rest of their medications. So lots of interesting questions that our data leads to future research and policy decisions. Next slide. As our CAPS team sprung into action around the as the COVID crisis, and recognizing that there was a new form of care exploding across the country, telehealth, and they are adapting the CAPS surveys of patient experience of care to the telehealth environment in a way that is going to allow us to be able to compare different patients' experience in person and telehealth. This is on a very, very fast track. I'm so proud of this team, and hopefully the beta version of this new CAPS instrument will be available this fall. Next slide. Our team, not to be outdone, our team on the patient safety culture survey is moving forward in several areas. One of them is workforce safety, which includes things like staff reporting on their use of personal protective equipment, but also things like burnout, things like the more classic things of sprains and falls from lifting and moving patients, and also the question of violence against staff. Very sad but important thing for us as a nation to deal with. This new survey will be out this fall. Building on our diagnostic safety work, the team is creating a culture survey around diagnostic safety, recognizing that diagnostic safety is part due to how doctors and nurses think as they create diagnosis, but it's also system level factors. Do people communicate well? Is the information available at the point of care? Are there too many distractions that may make people lose their train of thought? and therefore make mistakes. So this new survey is going to try to get at what are the system issues that may need to be addressed around diagnostic safety. So excited to see that move forward as well. I think we're almost done, Jamie and Tina. Next slide. Something we don't talk about, but is important to remind you all about, I think, is AHRQ's quality indicators. This is a suite of tools that are the foundation of quality improvement and quality reporting in American health systems. They are built on our HCUP data set model, but they can be run by individual hospitals. They have now been updated to take into account the shift to ICD-10. All of the different suites of tools have been done for that. In this process of modernizing and making these tools available and easy to use for health systems, the team really took a look at what are the most important measures, and they retired 21 measures, recognizing the need for a balanced set of things and for the ability to add new and improved ones moving forward. So not very sexy, but very, very important work that makes a difference in quality across the country. I believe that takes us to the last slide. Next slide, please. Oh, sorry, one more thing. Operational excellence. How could I forget? I apologize. Next slide. Wanted to give a shout out to our team at AHRQ that is trying to make all of the kinds of accomplishments we've just had easily understandable and known to the research community, to the healthcare delivery to community, and to people, the general public who benefits from this. Our real focus from moving from just traditional paper and journals and website into the social media space. Just since we've been talking to you about this, this project started about a year ago, huge increases in the uptake of our information using a variety of different social media. So if you're not a friend of AHRQ, on LinkedIn, on Facebook, on Twitter, please join us. Next slide. Then I think it says, okay, I'll get some more coffee and happy to answer any questions from the NAC members.
David, that was so much excellent information and very quickly and well presented. Thank you so much. And it just really gives a nice idea of the breadth of projects and evidence that AHRQ is generating. And me, like many others, I'm sure have accessed and used all of these great projects. We have a few questions coming in. I'm going to ask that you please just briefly introduce yourself, because we didn't do a roll call this morning. We're going to keep the questions brief during this part because we have a lot of interesting things to cover in our next section. We have the first question is from Susan Edgman. She has a question on the CAPS survey.
Actually, it's more of a comment.
Okay.
David, I just wanted to also mention that in addition to the work that the CAPS Consortium is doing on the telehealth visit survey, we are also working with NCQA to be able to adapt the telehealth questions for their health plan survey, but that will require, it can't be a visit-based survey because it has to look back over a member's experience in a plan, but hopefully that will give us data from a much broader audience about the experiences with telehealth.
Thank you, Susan.
Great. Thanks, Susan. We have a brief question from Patrick Romano. So Patrick, please just introduce yourself and let us know where you're coming from.
Right. Hi, this is Patrick Romano, and I'm from UC Davis Health in Sacramento, California. I was wondering, and I apologize for my naivete about the policy environment, but could you update briefly on the status of the PCOR Trust Fund and the training programs that are very important to AHRQ's mission that have been supported with PCOR Trust Fund monies?
Absolutely, Patrick. I think we did get a chance to talk about this a little at our last meeting, but for those who don't remember, and as an update for the rest of you, Congress passed a bill at the end of last calendar year that reauthorized the PCOR Trust Fund for 10 years, a full reauthorization, keeping the same distribution formula. So AHRQ still will receive about 16% of the trust fund every year for the next 10 years. That approximately is $100 million. AHRQ needs to spend that in 3 areas: dissemination of implementation and of evidence into practice, the use of clinical decision support, to support the use of evidence in clinical practice, and the training of the next generation of P-Core researchers. And AHRQ takes all 3 of those very seriously. And we are in the middle of a strategic planning process that we hope to update the NAC on in November or at your fall meeting. But Patrick, absolutely, we are continuing our investments in training. We currently have a grant program working around the country with training researchers embedded in health systems, understanding that that's how researchers learn to ask better questions, and health systems learn how to ask better questions when you train those researchers in that setting. Our next set of work will be creating funding opportunities for those researchers to move to do more in-depth research as well. So that's one thing to look forward to moving forward.
Great, thank you, Patrick and David. So I want to remind all the NAC members that you are encouraged to reach out to AHRQ, after the NAC today for additional questions or comments. They're eager to hear from you. So with that, we can move on to the next section. Jamie, yes? Okay, perfect. Okay, so David, I'm going to keep you on the spot here. So next we're going to get some information really important on AHRQ and the COVID-19 response. We have Bob McNellis and again David Myers, who are going to present to us some of the work that they've been doing. This is great and really exciting work. So we'll hand it over to you guys and hear this exciting information you have.
Great. Thank you, Tina. And I'll just start rolling, David. First of all, thank you all. Great to be here with you today. It doesn't seem like that long ago that we were here talking about some of our COVID work. Actually, it was about 110 days, I counted. Honestly, the last couple of months have flown by. But on the other hand, when we last met, there were 68,000 cases in the country of COVID-19. Yesterday, we had 60,000 cases of COVID. So things have changed dramatically since we last met. This slide did not change since we last met. I showed this slide last time we were together because I wanted to reinforce that we are really all in on COVID-19 and working closely with our sister agencies at HHS to really identify gaps and opportunity for AHRQ to contribute its unique talents and resources to the COVID pandemic. And we continue to develop short, intermediate, and long-term approaches to the response and the recovery efforts. And you'll hear more about some of our short-term accomplishments. I'll talk a little bit about those. And then David, I think, will lead us in a discussion of some of our intermediate and longer-term things that we're thinking about. So Jennifer, we can go ahead to the next slide. Great. I also, when I talked with you last, I shared a slide very similar to this one that had 4 lines of effort at that point in time. We've added practice improvement. And much like David characterized our accomplishments in terms of our competencies around health systems research, practice improvement, and data analytics, I'll use the same approach to follow that along. I'll also add a few notes about the response team that we've put together to work on these issues across the agency and with HHS and give you more detail on all these things. And that last item around the concepts for new COVID-focused initiatives, David will lead that discussion for us after I give you some of these other accomplishments. So we can go to the next slide, please. So shortly after we met, I think it was about 2 weeks, maybe 2.5 weeks after we met, Director Khanna posted a blog that essentially laid out for us many of the ways that AHRQ can uniquely contribute to the COVID-19 response. We actually reflected a lot on your feedback on that March 26th meeting. I took about 6 pages of notes from the discussion and what you had said, and hopefully you can see some of the things that you mentioned in this list of things that are around rapid cycle programmatic research, around expanding the use of telehealth and and understanding what that means, around practice improvement and what does that mean in the era of COVID, and what tools and resources can AHRQ develop to help support practice improvement. We also have worked extensively through our data and analytics teams to provide timely answers to some of the questions that have come up about the pandemic, as well as harnessing our online digital health knowledge platforms to move evidence into practice. And then we've also talked a bit about re-engineering healthcare through a systems engineering approach. And then lastly, ensuring patient and clinician safety. So let me break these out, and I'll talk a little bit more detail about all these. So let's go to the next slide. And first, we're going to talk about health systems research pieces. Honestly, the first time in that slide at the end about our social media platform is the first time I've seen that we had 300,000 views for our R01 FOA. That does not surprise me, given the amount of response we had to this. You were here on March 26th when we actually released the notices of intent for 3 actually funding opportunity announcements. One for an R01 on new research, and then 2 notices of intent to seek applications from grantees who are already out in the field to have supplemental funds so they could pivot their research to focus on COVID-19. We received tremendous interest in both of these. I think the thing that strikes me most about this work and what we've done here is from notices of intent when we were last together on March 26th to applications posting and deadlines, tremendously rapid. It's unheard of speed in my experience at AHRQ. And so kudos to everybody on the team who worked on these, was able to crank these out. And really, we've had a great response. Let me tell you a little bit more about the R01 if we go to the next slide. This was really seek novel, high-impact studies evaluating the health system and healthcare professional responsiveness to COVID-19. In our FOA, we highlighted these 4 buckets of work because these are the things that generally AHRQ is interested in. Applications didn't have to check, this wasn't a checkbox, but these were mostly suggestions. And I would say I probably talked to 40 or 50 potential applicants over the period of time this FOA was open. And most of them were seeking things in all of these. Some were having something that they wanted to explore in every single one of them. And some were outside of the box. Tremendous interest in this. A couple of unique features I thought you might want to be aware of. You probably know, but I'll mention anyway. These are 2-year grants. We're expecting a lot in a short period of time. Not only do they only get 1 month to write their application, they got 2 years to do the grant. And the grant awards are going to be very quickly done. We're doing an expedited review thanks to the team at OREP. Our Office of External Research Education Priority Populations is going to move very quickly on this. We'll be able to award, make 10 awards. One thing that was in this R01 FOA that you won't often see in R01s, and that is we ask people to put in a dissemination plan, research and dissemination plan. And not only that, they had to start disseminating within 6 months. So we'll start to have early observations and early findings within 6 months that will actually change the field. This will be timely research, really rapid cycle stuff. As I mentioned, I talked to lots of people who are interested in this. I think the field really grabbed onto this and see tremendous need for this kind of work. And there were tons of exciting ideas out there. A lot, of course, around telehealth, as you might imagine, but other areas that you just might not have expected. So it's a very exciting time. We're going to have lots of great applications, I think, and clearly we had a very enthusiastic response to this. So excited to get those out in the next couple of months. Next slide, please. Other research that has been come out is our EPC program has really been doing a lot of work. They actually have put together a new process for doing evidence reviews. Normally, for many of you know, evidence reviews take several months. Actually, they've developed a process that they were piloting as we came into COVID to do rapid reviews that take a matter of weeks, not months. This was just supposed to be a pilot process, but it turns out it may be a new model for how we do reviews in the future. And here are 3 of the ones that have knocked off early on here. First one is around masks for prevention of COVID. That's a critical question. This particular review was actually requested by the American College of Physicians. They are using the review to support their practice points for their members. The review happened very quickly within a matter of weeks. We found that the EPC found that the evidence was very consistent with the guidance that HHS has provided. And that's a good thing. Not only that, but this is actually going to be a living review. That means it will be constantly updated over time. As new evidence comes out, will update the recommendation or update the evidence review, and then ACP can appropriately update the recommendations. And we've already had version 2 is already out. So this is actually moving very quickly. The other one I want to make note of here is the allocation of scarce resources during pandemics. We've become very familiar with this. That one is still being developed right now. The interesting thing is that the original review was done in 2012. The review now is being done by the same team that did the review in 2012. In 2012, they found 27 studies. Now they found about 184. So they will be able to really update that review very quickly, very timely, important information to get out to the people who are responding to the pandemic. Next slide, please. So shifting over to practice improvement, here is our PSNet folks have really stepped up and put out some really important publications, I think. And if you're not familiar with PSNet, it's a national web-based resources that really features the latest news and resources on patient safety. And that team quickly put together a couple of primers, one on coronavirus and older adults and safety. And really there was some great information there about nursing home care, which has been very much in the news and very important part of the pandemic. Really also how to do human factors. We talked about system engineering at the front end. Here's thinking about how human factors can really help us improve safety in response to COVID. And then the most recent one was really around pharmacists, the important role pharmacists play, especially now that we're seeing drug shortages, for example, dexamethasone and many other drugs that are used for managing COVID. Pharmacists play a critical role in helping keep patients safe. David highlighted some of the guidance that the CAPS and the SOPS teams were really moving on quickly. I won't say anything more about that, except this is, you can start to see that everyone is pitching in and there's contributions from everywhere. And we'll go to the next slide, please. We also, speaking of responding quickly and pitching in, we actually had two projects that were well underway, and one was our ACTS program, which really was an online digital healthcare knowledge platform designed to bring evidence to the point of care. It had over 100 organizations involved in developing this care and trying to make sense of guidelines on a variety of things. They quickly pivoted and developed a new COVID Guidance to Action Collaborative to really try to make sense of all the guidance that's coming out of CDC, professional organizations, health systems, bring that all into one place so people can quickly access that information, try to make sense of it, and then use it to make evidence-informed decisions. So the ACTS team has done tremendous work, I think, to pivot their work around bringing evidence in general to focusing on COVID and trying to operationalize the almost overwhelming amount from the clinician perspective, amount of guidance that is coming out around managing COVID. Another project that we had that many of you are probably familiar with, we've talked about in the past, is our Take Heart program that was designed to increase the uptake of cardiac rehab in hospitals for patients who've had heart disease or heart attacks. And actually, as you can imagine, hospitals not in great position to think about cardiac rehab at the moment. That program quickly pivoted, allowed some pause in the cardiac rehab stuff, but has continued to maintain engagement with the hospital partners and helped assist them with COVID issues. And from what I hear, they've been really had some great conversations around those hospitals around how to address COVID and then how to work cardiac rehab back into the challenges that hospitals are facing around ICU capacity and things like that. So really quick response on some of our program parts of these new things. Next slide, please. Also, I just wanted to give one slide in particular to telehealth or virtual care because it's gotten a lot of attention. As you know, actually, you paid a lot of attention to it when we last met in March. We have done some things. Actually, it was very prescient of our EPC program, put out a evidence review last April on telehealth. How timely was that? And they actually published a commentary saying that, hey, the stuff we published a year ago still works. Telehealth, there is a foundation there that you can use that telehealth has some effectiveness. In addition, the PSNet team has published how to keep patients safe during telehealth. We tapped into our health literacy expertise to rapidly come up with a telehealth consent form. And then I just want to spend a moment about ECHO. We feel strongly about ECHO. We feel like it's our baby in some ways because we funded the first project in 2004. Hey, David, I think you were the program officer on that one in the early days. And as you know, Sanjeev Arora is a force of nature and really has taken ECHO in whole new ways. ECHO right now is a foundation for how we're doing a lot of the response to COVID. Where there's a whole healthcare resilience work group out there that is doing several ECHO sessions per week to train up ICUs and other providers, EMS and others, on how to manage COVID-19. This is a perfect example for me of how what AHRQ funds today can be used tomorrow in ways that we never would have thought of at the time. Who would have thought in 2004 when we funded this that it would be instrumental to providing support for healthcare systems around COVID-19? Who'd have thunk? But anyway, we'll move on to the next slide. And this is, of course, our data and analytics. I called them the first responders from AHRQ when we last met because they were out of the gate within hours of our engagement with COVID 137 days ago. Not that I'm counting. And they provided information to lots of our federal health partners around data on hospital occupancy rates and ICUs and ventilator capacity to help do modeling and figure out what to do with how to manage the national strategic stockpile. Our HCUP team has really been tremendously supportive of the states and helping give states data and insights and guidance on how to use their data to make their own plans and respond to the state needs for COVID-19. And then our MEPS team and others, those researchers have been looking at identifying insights on disparities and social determinants of health, and there's supposed to be a health affairs article coming soon. I didn't see it yet, but stay tuned for that coming very soon, and that'll be a really cool article when that's out there. Next slide, please. Okay, none of this could have happened without a great communications plan and getting this information out there. And I just need to highlight the strong performance of all the teams at AHRQ, but in the Office of Communications in particular, since we've last met, they've launched a webpage. We've published at least 4 or 5 blogs on COVID, highlighting the many tools, legacy tools that we have around team steps and CUSP, evidence now, all these things actually could be, many of them are useful today to addressing COVID. Every single one of these things that we've published that I've told you about had to go through a clearance and review process that they help facilitate. Well, we get lots of inquiries from product developers and patients and physicians that they're fielding. You can imagine all the guidance coming out of HHS, whether it's CDC, CMS, HRSA, whatever, all goes through clearance through us. They manage all that, really feature a lot of our COVID work in their electronic news. And then David highlighted some of the amazing stuff on the social media platform. So you can go to the next slide. I also want to make sure, you've talked about the products, I want to talk about the people. Some of the people, AHRQ has put together a team of people who work across the agency to try to identify our assets, identify gaps and opportunities, collect new ideas, sort of track our activities, and then coordinate with HHS. We've had a couple of different strike teams or strike team-like teams that have worked on our new initiatives, engaged in how do we do this new research, and really there's a team working on health disparities as well. And then we've really tried to engage fully with the HHS response. We have something to offer them. The data enterprise team, certainly I talked about that. There was a National Response Coordination Center that FEMA and HHS together ran, and many of us have participated in those teams to help bring the AHRQ perspective, the unique AHRQ perspective to some of that work, and I think it's been valuable and much needed. Next slide, please. And this could be my last slide, and just to highlight that it's not just us, the AHRQ staff who are doing this work, but our grantees as well. And David highlighted at least one of these. Here's a couple others. The 6 building blocks for pain management got a COVID twist to it. You know, we got people in the field doing this work, and we are doing our best as a small agency with few resources, but really good people and a whole lot of work to do to try to make an impact on COVID. And we think we do have a unique space for that. So these are just some of the things that we've done with COVID, and for that, it's not an exhaustive list, but gives you a good flavor for how we've tried to weave COVID-19 into the fabric of the work at AHRQ. And now I'm going to hand it back to David to lead us in a discussion about some of the proposals that we're thinking about for our intermediate and long-term approaches, and welcome your feedback on all those things. So with that, I will stop and hand it back to you, David.
Your enthusiasm is amazing, Bob. Everyone is noting.
Highly caffeinated.
Yeah, thank you, Bob. This is a time really where we're going to start shifting. We've been dumping a lot of information on the NAC to get you caffeinated, and now we're going to want your ideas back. But before we do that, I wanted to share with you that Director Khanna challenged the AHRQ team not only to do all of the things Bob just led you through, but to think about what's next. Where is this going? Where are AHRQ's, opportunities to meet unmet needs for the COVID crisis and the post-COVID world? And so what we're going to share with you right now are a series of proposals that the teams have developed that try to identify a need and a very specific potential AHRQ response. But all of these are things that would require additional resources to fully implement. So we are not doing any of these yet, but we want the NAC's advice as our people outside of the Beltway in the field to tell us, what about these resonates with you? Which of these do you think still, and times keep changing on us, so we know that these may not be We want your help fine-tuning them. Are there areas we're missing? Are there areas that you think of these that you would prioritize and say, yes, we want to help you get that one started because it would help us? That's going to be the question for you that Tina's going to lead a discussion of once I do this. Now, we sent these to the NAC members in advance on paper, so you've got all of this. And so that we can hear more from you and less from me, I'm going to go through these, I hope, very, very quickly. Next slide, please. The team came up with 5 specific proposals that we're going to go forward. And here they are, and I'm just going to read them once, and then I'm going to go quickly. Evaluating and learning from the natural experiment of how the healthcare system responded to COVID-19. 2, the natural experiment in the massive expansion of telehealth, and what can we learn, and what do we keep, what do we change, what do we need. 3, the need for data on how health systems, what resources they have, how they're organized at a state and a national level to be able to plan for emergency and surges. 4, thinking about how a systems engineering approach brought to healthcare delivery systems could help them reorganize care in a way that makes more sense, makes them more nimble, have the ability to create patient safety and quality in regular operations and in times of crisis. And the last one, which clearly right now is getting a lot of attention, I think importantly, is how to maintain staff and nursing home resident safety during the COVID pandemic. So rapid fire, here they come. So we know that the health system was strained. People did amazing work to overcome the crisis, but we exposed some problems. There are lots of knowledge gaps out there about workforce, about delivery, about logistics, about materials, both in hospitals and emergency rooms, in nursing homes, and in primary care as well. Next slide. Lots of questions that you could ask. All of these, though, lead to what do health systems professionals and policymakers need in terms of evidence to inform decision-making tomorrow and in the future to best treat patients and allocate scarce resources. Next slide, please. So our proposal is to invest in a series of rapid cycle studies on scalable strategies taken by healthcare professionals and systems. We would do this through both looking at immediately and longer term needs. And as Bob said, for our current work, we would challenge our grantees to start making their research findings and their learnings available in as soon as 4 to 6 months. Next slide, please. On all of these, we developed a AHRQ slide. I'm not going to go over these for you now, but these I'm putting in here in case you are talking with people later in the field and want to explain to them about AHRQ. So these give you all of the pieces, but we won't go through this right now. And let's speed up the slides. Next slide. Our second one on telehealth. Clearly, exceptional rapid expansion of the use of telehealth changed the delivery of healthcare in many ways. We want to know what worked well and for whom, and how telehealth moving forward can deliver safe, high quality, high value care. Next slide. The list of questions that people are asking about telehealth is enormous. Even though we do have an evidence base we're building on, there are still many questions. How do we ensure that telehealth increases access and decreases disparity? What visits are best done in telehealth and which still require in-person care? How do you train staff? How do you train patients? What technologies are most effective in what situations? How do you keep trust and confidentiality moving forward? Next slide. So what does AHRQ want to do? Very similar to what we wanted to do in health services research, a focus on telehealth, 3 waves of research grants, again, focusing on lessons learned in the short term and getting those out. But additionally going on that we have the potential to bring people together in learning collaboratives, engage primary care specialists or any other sector of the healthcare delivery system on what they need to know about telehealth. And our team was also very interested in pulling all of this information together on an ongoing basis in implementation guidance grounded in what we learned from the research. Next slide, AHRQ, next slide. Third, supply side data. You heard about this earlier from Bob, the importance of understanding the gaps, or actually you heard this from Gopal, excuse me, that there are gaps in the national response because we didn't have the data. There are many things HHS is doing to improve that data, but many of them are focused on the immediate needs of understanding COVID as opposed to the delivery system caring for people. And so supply side data about healthcare and healthcare delivery at a state and national level could be very, very powerful and helpful. Next slide. The kinds of questions one could answer: where will shortages occur? How can care be diverted? What proportion of hospital revenue is derived from elective procedures, so you can understand how to keep practices viable? Other important questions. Next slide. The team at AHRQ created a set of solutions to this. The first was a physician and physician practice database. It is a pretty well-kept secret that we cannot, as a country, identify all the physician practices, ambulatory practices in this country and understand their capacities. AHRQ would like to start answering that question. We'd start it with a particular state, such as Florida, work with the state very quickly to get all the data to build that census of their physician practices. Over time, expand that to the rest of the country and grow the database and make that available to other people. As we do that, we would move to looking at hospitals, emergency rooms, nursing homes in a project that would take probably up to 3 years to fully build, but could be started within a year. And most importantly, then start using those data sets to create analytic modeling tools that allow people to ask questions to understand how the healthcare system can and is not ready to respond in a time of crisis. Next slide. Why AHRQ? You know this, but it really does build on our work in HCUP and MEPS. Next slide. Systems engineering approach. This is asking you to think in a completely different way, but on the health system levels, we saw how different hospitals struggled. There are questions that people running systems have: how many ICU beds are available, what staff is available to come in for the next shift, what's the current waiting time, how many things have been sterilized. Next slide. We've seen that there is a model called a command center that some rare number of places around the country have started making progress in. Nobody has a comprehensive one, but you can see the outlines of what a system engineered command center could do, how to bring all the data together to empower decision making. Interestingly, many other fields endeavor in the country have these things, and within the healthcare we see it within emergency response teams, such as what was stood up by FEMA and HHS as a command center. But our hospitals and our health systems in general don't have this in the country. Next slide. So our response at AHRQ was to partner with system engineering experts to build a model and do that in a few hospitals, diverse hospitals around the country, show how this can be done, disseminate a blueprint of this model, and do it in an incredibly rapid fashion. We believe we could do this within 12 months. This kind of work, next slide, would not only have value during a crisis, it would actually create a model for improving quality and safety and using data on an ongoing basis during normal operations as well. So really something AHRQ is excited about. Final set, next slide. I am actually breathing. Sometimes I feel like I'm not. Safety in nursing homes is incredibly important. We know the problem. We also know many of the solutions. AHRQ already has tools on how to teach people, based on the Ebola crisis, how to use personal protective equipment, how to do infection control, how to use the planned environment, the physical space, and keep people safe. We need to get that information out to nursing homes as quickly as possible. Next slide. This proposal is actually a little older. It came earlier, but we said we would use both research and practice improvement, thinking about how to increase or improve disinfection for COVID and teach people about PPE, but also think about infection control in nursing homes using the built environment as well, and do research in both of these areas, and then take it, create materials, training materials, and send it out. We realize the field has continued to evolve, but this concept, we think, is still very, very important. Next slide. This, of course, why AHRQ. part of this is that we've done this with the community, and it's partly that creating national learning networks using tools such as Project Echo is something we think we can do really well, and we've proven we can do this working with nursing homes using our CUS program, focusing on catheter-associated urinary tract infections in hospitals. Okay, final slide. So we're going to turn this over now to all of you to reflect back to us on what you just heard. Do these proposals still address the most important gaps? Do you think we, if AHRQ was funded to do this work, could make a difference that was important to the American people? Are there ways we can expand or focus, refine these proposals to increase either their relevance or their value? And are there needs facing the delivery system that you believe AHRQ is well positioned to address that we haven't thought of yet? And if so, what do you think we should be doing? And with that, Tina, I'd like to turn this over to you and hear from the NAC their ideas. Thank you.
Great. Thank you, David. That's so much information, very exciting proposals. I was wondering, before we turn it over to questions, if you could speak a little bit about the budget. I mean, we understand that AHRQ has a small budget to work with. So do you have any idea, an associated budget with these different proposals? Can you speak to that?
Great question, Tina. And so to get people thinking, I think the way most of these proposals, in my professional judgment, they're very scalable, clearly, but all of them are in the $50 million range, I think, to start with. Some of them, working with all nursing homes in the country might take more than $50 million. The research, I really believe telehealth research could, $150 million would not be too much to invest over the next 3 years. But to start with, if people are thinking of projects, you could start with a $20 million investment, which I think is closer to what the systems engineering to get started would take, and then go up from there. Does that work as a frame for you, Tina?
Yeah, that's great. And it helps us kind of think about how to think about the impact of these and the cost. We have lots of questions coming in, David. So I'm going to turn over to questions, right? I believe our first is from Patrick Romanos. So Patrick, please, the floor is yours.
No, I'm sorry. That was already covered.
Oh, okay. Sorry. Ram, then we'll move on to Ram. Do you, Ram Arju?
Unmute. Okay, I'm unmuted now.
Perfect.
Can you hear me?
Yes,
okay.
We can.
It has been a phenomenal presentation, but I just wanted to, identify certain issues AHRQ should be interested in. This is based on my op-ed I wrote about what we have learned in New York City and Northwell regarding this virus. This is an op-ed in Modern Healthcare about a few weeks ago. The first and the foremost is it is all about when the people got infected, how will we treat them, right? That's the health system responsibility, but we need to really advance it a little bit better. How can we get the community respond to us in a way so we're not overwhelmed with those cases? How do we, that should also be a health system's responsibility, not treating patients, but also working with the community-based organizations to prevent people getting infected. To do that, there are three things which we learned. One, who do we test? Because one of the things we did was we tested the wrong people up front, not the right people. So in North, one of the things we looked at it is people who has got a high social risk scores tend to have more infection, more admissions, more death rate, and more ICU intubations. And the second question was, where do we test them? We tend to test them mostly in the if you have a car, then it's okay. You have a big parking lot you can drive into. But if you do not have a car, then these people crowded across the large hospital systems. In New York City, is basically health and hospitals. People have been lining up outside. All of them are potential infections, and they are basically waiting for 3-4 hours to get tested. So the testing has got to be done instead of 10 people doing the testing in one place, we can have 10 places with one person doing the testing. So we need to really move that across. And we learned that very, very late in New York City before we started testing in the churches and the religious places locally and able to do that. Second, we didn't know how to engage the community leaders correctly in trying to figure this out. And that has really had a big impact on them. The third thing we had was a lack of health literacy, because in spite of all the communication by various leaders across the country, to understand them, we have to be either very proficient in English, or we have to have a literacy level, at least a high school education, college. So Northwell, again, we did a health literacy platform, which is a chatbot with the converser. Basically, the receiver of the information can actually take it down to the literacy level he or she needs. It is given over the smartphone, and also the language of the choice, because the translator helps you to do that. So the health literacy was not very well appreciated. So the people who really didn't understand how to practice social distancing, didn't understand how to wash their hands, how do you cough, all those things really had a big issue. So there must be something we need to do to improve the health literacy of the people. Last but not the least, before I close up, is the telemedicine. Telemedicine is great, it'd be wonderful, but we need to, if you do not want to create another health inequity due to the lack of high-speed internet or the lack of internet services across the country, we need to have the internet as a part of the benefit for either the government-based insurance companies or the other insurance companies. Like a lot of insurance companies offer gym benefits as a part of their coverage. So we need to think about, if you want to use telemedicine extensively, we need to have that high-speed internet available to everybody. Otherwise, we'll be creating another group of health inequity in this group. So with that, I just wanted to, I'll just stop and I'll wait for any of your comments.
Please send us your editorial, and we'll take all of that into consideration. Those are all very, very important points. Thank you.
Great, thank you. So we have, again, a lot of questions coming in. I'm going to ask it that you keep your questions brief so we can be sure to get to everyone's point. Peter is next on our question list.
Hi, so just again, briefly want to extend my kudos to the team. I think actually to your questions here, David, a lot of the things you all are doing and have proposed do address very important gaps, and I think will be very meaningful and impactful. So just want to say that at the top. So what I was thinking about, spurred by your questions, is what additional things could be done, and the thing that's most challenging, and I imagine it's challenging for AHRQ, but I want to put it to you, is this is all moving so quickly, and the information that everyone needs across the health systems is so pressing as we see surges and need to respond. I know here in Indiana, we're working across the state with our health system partners to try to facilitate sharing of information. We've created a collaborative across the state that brings people together to share that kind of information. So what could we do to enable more rapid and real-time or near real-time collaboration and sharing? I think that's one of the things that's sorely needed. And then maybe slightly less rapid than that is, have you considered, and I'm sorry if I missed it in the deluge of amazing things you guys have presented here, but could you also consider perhaps even smaller grants to just enable the rapid publication, maybe even endorsing special issues or other things that would allow for the natural experiments that are happening right now to be published quickly, outside of the usual sort of grant cycle, even the more accelerated grant cycle. So sort of a couple different parts to the question of, really fast and maybe a little faster than traditional, and then, and then the like. So if you could respond to that, that'd be great.
Oh, thank you, Peter. I actually have a question back to you. We've seen that same thing of communities coming together in states, in specialty societies. It's actually almost overwhelming, recognizing how many different places you can go to learn about COVID and to share. We do have grantees that are currently helping do that. I think I'm personally a project officer on a group doing it with hospitalists, internal medicine hospitalists. So really exciting work. It's almost daunting to think of how do you put something in to support that. Given how much there is, do you think there really is room for AHRQ to try to help organize that, or should we continue just allow the community to self-organize?
Well, I think this is a great question, and I obviously not sure that I have the answer, but I think that to your point, there is such an incredible amount of activity that perhaps AHRQ's role, if nothing else, could be to enable the collection and inventory of all of those kinds of activities so that people at least understand. I mean, there's a way, there's probably a useful way to think about how to categorize and catalog and grow those kinds of activities. I think a lot of these things happen anew because people don't realize there's something that already exists that could be beneficial, right? So we don't want that. And then there are probably other areas where there are in fact real gaps and something needs to be filled. So I do think there's a role there. I'm not exactly sure what it is. But in addition to that, I think, perhaps it's a matter of, even a network of networks or something to that effect that could be considered as a role for AHRQ, specifically in the area of both the health system, the hospital-based activities, but then also, I think importantly, and you mentioned this, the nursing home and long-term care facility space, where there is a real paucity of knowledge and data and sharing, because we just haven't historically, as you know, placed as much emphasis on that as we have on the hospitals.
Those are great points, and we'll think about that. And your second question, I'm going to ask you to think about that when we come back about health services research at the end, because that's asking us to think differently about how to use research grants, and I think there really are opportunities. So we'll keep thinking with you on that.
Very good. Thank you.
Others?
And if I may quickly add, Tina, building on what David just said, Peter, if you can think about what could be some examples of where you can use rapid cycle research, sort of moving away from long-term research. And Tina, you and I have talked about that we need to find new approaches. Is that a gap where AHRQ can play a vital role?
Very good. I will think about that and let others jump in. But I'll enjoy the continuing conversation. Thank you.
Yeah, and I think, Peter, this is a great opportunity for us NAC members to really think about, how do we get this word out about these different types of proposals, that AHRQ is thinking about? Can we, we each have a wonderful, very expansive network of our very own. So can we think about, getting the word out via blogs, via Twitter, via other things to really help disseminate these messages and get more public feedback? Where are the big gaps? I think that's really important that we help get this message across to our communities, because we each have a slightly different community that we work with. And so that would be an important point. Also, I just want to build on one of Peter's questions, or Peter's responses, is that, we're identifying these gaps. There's lots of opportunities for AHRQ to play a role here. We're also seeing a lot of evidence that comes out because we're working on this so quickly. Evidence is coming out and being retracted. So does AHRQ have a way to think about how do we really keep track of the evidence that's coming out and synthesize this and really understand, when information is being retracted? Does everyone know that's being retracted? How do we manage that type of information? Because there is such a quick cycle here. We're seeing a very broad range of all different levels of evidence coming out. So there might be an opportunity to think about that also.
My colleagues from the UTC program, we've been showing you the innovation they've been making. You're challenging them to go further, and that's great. That's exactly the kind of thing. The living review process that we set up every 2 to 3 weeks, summarizing, begins to address that, Tina, but I don't think, I think you've added more important layers in the gray literature, and now there's really exciting opportunities. People are putting their things out to get it out before it's been peer reviewed, which is exciting and helpful, but also comes with some potential drawbacks, as you said. So we're wrestling with that, and thank you for reminding us we need to keep wrestling with that. Okay.
Great. Okay. Moving on to our questions. Next, we have Kathy Bradley.
Hi, Tina. Thank you. So I have a couple comments. First, with regard to telehealth, and what I think is missing is there's no research that I heard mentioned on payment policies. And payment policies so much drive who adopts telehealth approaches. It drives a lot of the confusion that's in the field. In many ways, I think that the technology problems are more easily solved than the disparate payment policies that we have in place, starting from Medicare, which instituted a wholesale waiver of many of their restrictions so that telehealth could be more readily adopted. But then Medicaid lagged behind, and each state did it differently. And then private payers also, with requirements around payment parity, really strongly affected who adopted what telehealth and the extent that they made it available to different populations. So the uninsured, the rural health practices, and like I said, even confusion among individual practices. Being able to be reimbursed across state lines is another area around telehealth that affects its availability. So I think that's an area of research that AHRQ can lead that no one has looked at. And if we don't think about payment policy and the incentives that are in place and the confusion that it's caused, I don't think we'll see it widely adopted and widely available. And then what goes hand in hand with that is issues around equity and access and how payment policies has affected that as to who gets telehealth and who doesn't. So first area of comment. The second is around health systems redesign and infrastructure in response to COVID-19. And I think all the areas that AHRQ mentioned are fantastic. And the one place that I saw a gap was around hospital closures. Places not just redesign of how we're doing what we're doing so that we can do a better job of it, but places that closed prior to this pandemic that left wide gaps, and to think about the impact and how is it we either go back reestablishing those healthcare services or that we repurpose other delivery mechanisms to fill those particular gaps. And then last is David's comment about quality measures. And you mentioned how unsexy quality measures were. And I agree wholeheartedly with that comment. But I think PROs are pretty sexy. And if you could bring the two together to have PROs integrated as quality measures, I think would be important in terms of how we evaluate responses to emergencies, how we deliver quality health care. If we can bring PROs into these quality measurements and to think about things about equity, access, and financial burden as part of patient-reported outcomes. So those are my three main areas of comment, and just want to thank you for all the efforts and all the enthusiasm.
Oh, thank you, Kathy. Those are all brilliant and push us in really interesting directions. You just really insightful. Thank you.
Yeah. And I would like to add, Kathy, that I know that in oncology care, they are linking the PROs with the quality metrics. So I think it's Oncology One is a new bundled package that's coming out that links PROs with quality measures. So I think it's important we start thinking in that space and kind of turn quality measures back into like a fun, exciting area of research.
Exactly.
Fair enough.
Yeah.
Fair enough.
We have another question coming in from Yang Li Yu.
Yeah, can you hear me? Thank you.
Yes.
Can you hear me? Yeah, thank you. First of all, I really want to applaud AHRQ's efforts to have this filling the gap, use evidence to address emergent issues during the COVID-19 medical care. I think both providers and consumers, patients have all very appreciated this tremendous efforts. My comments or question is focused on based on my concerns that lack of a national standards for doing this COVID-19 care. One example is that I was at our state infection committee meeting, and we talked about the infections in long-term care facilities, and lots of questions raised how residents got infected, they're locally infected, or they're infected by healthcare providers actually bringing in. And also their infections, some residents, after they recovered from COVID, they were sent back to the facility. And there have been concerns even on national news. And it really struck me that there's no national standard, evidence-based, and what is the best practice to practice those vulnerable population in terms of COVID infection. Should we send them back to the facility, or should we put them in a separate place, like a field hospital temporarily until, to separate them? And there are facilities, long-term care facilities, they separate them into different quarters, but do all long-term care facilities doing that, or how they doing it? We don't know. And like Peter brought this question, is there's network, people just, spontaneously gather on to share experience, share knowledge. And I think this would be a great opportunity for AHRQ to bring in as a national leader to use evidence research and data sharing, results sharing, to set up a national standard or the best practice to reduce COVID infection. I know that might be one of the other concerns I have is the disparity between big academic centers like universities, like I'm with the University of Washington, and people get a grant, write papers, and then that would be very easy to get knowledge disseminated because people gather and talk, they have a good network. But what about the rural community, those hospitals? They probably rely upon state hospital association to get the knowledge. So I thought that maybe AHRQ would think about have some liaison and to connect with a different state and consumer group. I mean, this is also part of a consumer patient education also, what is the best practice? So they will know when they go into the facility. And like whether they will be tested, if they have elective surgery now, many states allow that to resume, where they get tested before surgery. Some facility do, some don't. They just measure temperatures and based on the symptom. So there's again another lack of a standard based on the evidence. So I really hope that AHRQ would gather all the information and disseminate this knowledge and find some best way to, make people widely know what is evidence-based, the best practice to be safe from COVID infection. So that's my comments. And maybe a question. I don't know, it's a long-winded. I don't know if AHRQ has thought about this to make a national standard, some practice in that regard. Thank you.
So thank you, Yangling. Thank you so much. Your perspectives are so valuable to help us continue to keep our minds open. One thing I can reflect back to you is that AHRQ is part of that, as Bob said, a combined effort across Health and Human Services, AHHS, in partnership with the states. And our challenge, I think, to go forward is to bring ideas like that forward, because we may not be the best ones to lead all of the pieces you said, but those are all needs we as a system, a department should be bringing, the best guidance, the best practices. And I'm not sure that AHRQ is the best person or organization to lead the information for patients. We're very small, and that takes, I think, a larger communication thing, but the need is still great. So thank you for bringing that to us. And maybe as NAC members, you can say to us, yes, actually, AHRQ should be using the evidence people and become the evidence people for the American public, not just for the healthcare professionals and systems that we traditionally have thought of as our primary way that we help improve health. So that's what we rely on the NAC to do. So thank you for all of that. And everything people are saying we're taking down, and we'll sort out how best to address. So thank you.
Yeah, I really appreciate you. Could I just make one quick?
Well, we have about 7 more questions, yeah, okay, and we only have 3 more minutes, so I need to move on to another one. Thanks.
Okay, all right.
And you all have my email. You all have my email.
Yeah. Okay, we're going to move on to Gregory Alexander. Gregory has a brief question he'd like to ask.
I do. I just want to one comment. Thank you. One is as soon as you possibly could share something about the timeline for the 3 different proposals that are coming, that would be really helpful. Because we can prepare ahead of time, but there's a lot of competition, you know, for these types of proposals, and I want AHRQ to be, you know, positioned and allow researchers the position to be able to be competitive for these awards. So a timeline would be really important. Now, my second point is that I work a lot with international organizations. I had a Fulbright, and I work with the International Institute of Education and the Fogarty Institute. And international perspectives around the COVID response are super important. Other countries in the world are looking at the United States and how we're responding because we have such a big issue with the pandemic. So I would encourage, as part of your proposal, to think and encourage common data sets around international perspectives so that we could begin to share and understand how people are responding. My work's in long-term care, so I'm working with people in Australia about long-term care situations. And I think in regards to your comment about sexiness of QMs, I agree sexiness of QMs may not be that important as sexy here in the United States because we've had them for a long time. But in international societies, like even in Australia, that's pretty advanced country, they haven't had quality measures in long-term care for a super long time. And so many countries, these things are sexy. And by encouraging those perspectives, I think we might have a different viewpoint on what we can help, that could help us and also help other people in other places.
Greg, thank you very much. That really helped. That expands our thinking. Thank you for the reminder about what we can learn from the rest of the world and how thinking globally can improve AHRQ's ability to improve health here in the country. I have a feeling I'm going to regret using the word sexy and quality measures in the same sentence, no matter what happens with all of this. Just so you know, I'm an evidence geek. It's sexy to me. I just realize I'm not normal, but thank you.
Perfect. Thank you. A lot of great comments coming in. We're going to move to Susan Edgmond.
Hi, thank you. Just ditto to how great all this is. I have 2 questions about research focus. One is we're seeing some pretty serious issues with our workforce safety, especially in the people that live in our most diverse communities that have frontline positions that aren't clinicians, police and security, transport people, housekeeping, etc. And I'm wondering if there could be a focus on this because it has a wide-ranging impact on community spread as well as just their personal safety in either the engineering or in the safety universe. And my other comment is, you know, COVID has really, really, really terribly impacted our foundation of primary care and primary care practices, which is also somewhat related to the comment about telehealth reimbursement. But I think there are lots of other organizations that are working on measuring the impact of COVID on our primary care foundation, but potentially partnering or thinking about research activities that could help shore up the primary care practices and the impact that we're seeing on them. Even practices that are affiliated with large health systems that have a lot more resources than independent and rural practices. That's it.
Thank you, Susan. David, any comments? David's having some technical issues. We'll let David get back to you if he has comments once he works out his issues. Okay, let's move to Andy. And just to let you guys know, we're cutting into our break. So if we can keep our questions brief, I want to try and get to everyone. Andy, please.
Yeah, so just two quick comments. So one would be that this is an opportunity to leverage AHRQ's strengths in data and analytics, and the specific area would be coming up with a set of quality metrics related to COVID care, both short-term, i.e. risk-adjusted mortality metric that would also account for socioeconomic status and some of the disparities that have been talked about. And two is longitudinally following survivors and looking at their health outcomes, impacts on utilization, quality of life, 3 months, 6 months, 12 months. I think that's going to be increasingly important. And then the next piece would be building on some work that AHRQ has done previously in terms of transitions of care. So COVID is going to be part of the fabric of our lives for the foreseeable future. So we need to start thinking about it in terms, almost like a disease management strategy, like we do for diabetes, CHF, COPD. And I'm thinking back to Project Red and some of the collaborations that were done in transitional care. How you discharge these patients, the follow-up, different mechanisms for whether it's a virtual visit or making sure that young patients with no comorbidity versus those that are chronically ill. I think that is an area that AHRQ could provide a lot of good information and insight into in terms of the transitional care management of this particular disease. And that's it. 2 suggestions.
Great. I think maybe putting COVID back to quality measures can turn us maybe back into the sexy scene, right, David?
And Andy just pushed us to think about longitudinal care, which I'm so glad you did. I think it's a huge need. But I want to, as you've all started exploding my head on international longitudinal and payment and all these absolute things, if all of the NAC members during the break would sit down and said, if you got in an elevator with your senator and you knew they were about to vote on a new COVID supplemental package, and you wanted to say to them, because you knew them, give AHRQ $50 million and tell them to do X. You've heard all of these ideas. What's the idea you're going to pitch? Let's think about it, and you can tell us offline which ones you want to do. And I hope you do get in that elevator, but that's beside the point. Just how do we help us prioritize as well as expand our thinking? Thank you.
Great.
Back to Tina.
Thanks, David. Okay, we've got just a few more questions. We're going to try and keep them brief. Asa, I believe you had a question you'd like to propose, ask, comment, something?
Sure. Thanks for the opportunity. Really briefly, I really want to vociferously emphasize and agree with what Kathy said. What's missing here and what in my mind is most important is for AHRQ to have a research agenda on payment policy as it relates to the delivery of healthcare. I think that we can all agree that what COVID has exposed is the fact that hospitals have a dangerous reliance on elective surgeries to make margins, and outpatient facilities have a dangerous reliance on in-person visits. And so beyond just talking about the fact that more money is needed, because everyone always needs more money, what AHRQ can really help us understand is not just amounts of money, but forms of fund flows, prospective versus visit-based, global budgets versus fee-for-service, et cetera, to really help us understand that payment policy needs to be a part of pandemic preparedness. COVID has shown that idiosyncratic fee-for-service historical payment is not just unfair and problematic for all the reasons that we know, but we can't actually deliver good quality care because we have these fatal flaws of being reliant on the hospital level on elective procedures and on the primary care and outpatient level on in-person visits. And everything else in my mind, quite frankly, stems from that. And so I would really urge AHRQ to focus a research agenda there.
Yeah, thank you. That's a great comment. David, sorry?
I just said terrific. Just what we need to hear. Thank you.
Okay, so we're going to have a question from Gretchen and then Edmondo, and then we'll take a 10-minute break. So Gretchen, please.
Thank you. And no need to respond to these, David. We can follow up later. The first thing I wanted to say was to endorse Dr. Raju's earlier points about health literacy, and maybe we could have AHRQ play a role in defining best practices, in reaching the general consumers and getting the right messages across. So if I had 50 million, I think maybe 20 million would take care of it. I don't know. And I would also emphasize Dr. Raju's point about the internet infrastructure. That is pretty serious in a lot of parts of the country. The second area I wanted to comment on was on telehealth, and maybe in that research that you're doing, if you could identify what consumers like and dislike about telehealth visits, independent of just the internet question. The third area I wanted to comment on was on the supply side, the primary care practices. And I wondered how the primary care practice database will address racial and other vulnerable populations and services to them. And I was a little bit wondering about both the physician database and the hospital census in terms of how well that will be coordinated with the AMA and the American Hospital Association, which already has tremendous databases rather than us just duplicating it. And then the last comment, this builds a little bit on what Dr. Yu said about nursing homes, and I am concerned there about the role that shared staff play, mostly nursing assistants, in working at multiple nursing homes in terms of spreading the infection, in as much as asymptomatic spread is a problem, and making sure that our research addresses that and the reasons for shared staff working at multiple places and getting to some of the root causes there. Also in that nursing home area, I was hoping that AHRQ is finding a way to support the members of the new CMS Independent Commission on Nursing Home Safety and Quality. And I know they're to finish in September, so the time is really short on that. Thanks. On your to-do list, David.
Thank you, Gretchen. Okay, well, last comment will be from Edmondo, and then we'll take a short break.
Okay, so so David kind of challenged us with the 50 million idea. So I would double down on virtual, actually, on that 50 million. I mean, I'm talking inpatient, outpatient, remote patient monitoring, equity, data integration, policy, really understand the impact and importance of leveraging virtual care in kind of thinking of it as a bit of an umbrella. That's actually where I would spend the time and attention. My question, though, is I'm wondering, is there a role here, an opportunity here to really unpack the impact of the pandemic on the clinicians themselves? We talked, I heard a little bit about, workforce. There's also actually the clinician infection rates themselves. What about the stresses around this? What about the ability to actually pivot towards providing virtual care? There's an assumption that you can provide virtual care just because you're a clinician without any additional training, right? So I think there's a lot of different pieces in there, but I don't want to lose just how impactful the pandemic has been on the clinicians themselves, and I'd love to kind of understand that a little bit more.
Edmundo, if I may ask a question, and maybe we can take it offline. Are you seeing any COVID-19 acquired infections? For example, somebody's at the hospital and they're not really COVID-19 patients, but are you seeing that trend or any instances of that?
I mean, anecdotally, I don't have the data, but definitely seeing that. And it's, for example, we've got a significant proportion of our nurses are out COVID-19 positive. That impacts care across the entire organization when that happens.
Great point.
The reason why I asked that question was because a recent study showed that in the United Kingdom, in England, that rate is close to 20%. I just briefly read about it, so
that's right.
Area that I would love to have NAC think about, and if they have any indication or they have a sense. Tina.
It's a big important, and it goes back to my other point about virtual, because not all of the folks who are out are incapacitated. They do need to be isolated, though. So if we can still leverage our clinical expertise virtually, it decreases the impact of the positivity that we're having in the COVID-19 with our clinicians themselves.
That's a brilliant idea. Brilliant.
Great. I think that's a great spot to take a break, and we can kind of think about all these comments. Thank you so much for this great presentation of information, David and Bob. Let's take a 10-minute break. We'll come back at let's come back at 5 to the hour. So 5 to I guess it's 12 Eastern time, 5 to 9 Pacific. Please, everyone, stand up, take a break, and we'll see you in a bit. If you can, to let us know everyone's back. We've had a really exciting morning. I think there's a lot of things to think about. We encourage you to reach out to AHRQ with additional questions, things you would like to share, and also to, encourage you to share the information you're learning here among your colleagues, your blogs, etc. Get the word out about all of this exciting information that AHRQ is doing. So next up, we have, we're going to have improving health services research across the federal enterprise. We have Jamie Zimmerman and David Myers, who will be presenting some of this information. So Jamie, over to you.
Super, thank you, Tina. Can everybody hear me okay? I'm so happy to finally be here where I can actually see your faces this time. So I'm glad we have a platform that works. It was a great discussion this morning. It made me think, though, into my yoga classes, that we probably need to just take a moment and take a couple deep breaths so we can kind of recenter ourselves. So I'm hoping you can all do this with me. In through your nose and out through your mouth 3 times. And I hope that kind of captures not only how to reset ourselves, but it also makes me capture how I feel about finally getting to share this report with you after 2 years. So, I'm glad that it's now out in the public. It's been shared with NAC members, so folks are starting to digest this information here, and we're beginning to start conversations, and we're really excited to be starting this conversation with you all today. While there are a lot of details in this report, we really want to focus this, and we're happy to answer any of these questions about any details of the report. Please shoot me a note offline, and happy to get into that. But what we're really hoping today, and the real primary goal of this discussion, is to really think about and focus on how we can move this forward, and specifically with our NAC members' input on particular topics that we'll get to in a moment. Jen, next slide, please. So I'll start off, next slide, please, Jen. I just want to start off and thank my internal advisory group here at AHRQ. You know many of them, Dr. Arlene Bierman, Dr. Frances Chesley, Dr. Patricia Keenan, Bob McNellis, and of course myself, and they were very instrumental along this entire process, really shepherding this report going forward. Next slide, Jen. So just to take us back, because I know it's been a while since we started this study, but this study came from a congressional mandate back in 2018, which authorized AHRQ to contract with an independent entity to study HSR and PCR supported by federal agencies from beginning into FY 2012. And really the motivating policy questions behind this study are: what kinds of HSR and PCR are funded by the federal government? And what are AHRQ's and other agencies' roles in funding this research? And with that, we awarded a $1.1 million contract to RAND. Next slide, please. The key study questions were, we were really asking here is, what are the types of research gaps, and barriers to greater impact of both HSR and PCR? And really, this provides an opportunity to provide evidence-based analysis to inform policy. And it developed the first ever global understanding of the breadth and scope and impact of the federally funded HSR and PCR portfolios. And it gained us insights into how we could better align these research programs to serve the needs of the evolving US healthcare system. and provided balanced evidence information that AHRQ and other policymakers can use in helping shape the future HSR and PCR agenda. Next slide, please. So as I mentioned, this was across HHS and included the VA, and it ranged from FY 2012 through FY 2018. And we looked at extramural for quantitative and qualitative aspects, as well as intramural work for the qualitative portfolio descriptions that are in the study. And we focused on grants and contracts, and really it was primarily because that's the data that's available. Next slide, please. So this was key to the study early on, was having these real clear definitions of what we considered health services research and primary care research. And this was an iterative process along the course of the study that came from feedback from outside stakeholder groups, as well as our TEPs and others. Next slide, please. There were 3 key study methods. The first one was technical expert panels. The second was stakeholder interviews. And then we used an environmental scan and portfolio analysis. It's a mixed method study with both qualitative and quantitative approaches. Next slide, please. So RAND convened 2 technical expert panels. There was an HSR TEP made up of 9 members, a primary care TEP made up of 11 members, and all of these folks had a range of expertise. And there was a considerable amount of effort spent really making sure that we had a diversity of folks participating in this. They met in person once and twice by teleconference. And then, as I mentioned, it was supposed to be an independent study, and so there was a large amount of attention spent on an independent expert, and as well as other procedures to help make sure this was as independent as possible. And then RAND used a systematic transparency sampling process throughout. I should also mention, we also had a federal advisory group made up of our sister agencies, many of which are our ex officio members on this call, where we met, who also helped validate a lot of the data collection, as well as the descriptions. Next slide, please. RAND conducted 50 semi-structured stakeholder interviews, and again, a lot of thought was paid to who these folks were: researchers, healthcare delivery system leaders, state level folks, and as well as federal research leaders and others, and made a considerable amount of effort to balance the input across stakeholders. And then RAND used a thematic analysis of interview and TEP transcripts. Next slide, please. Moving on to the environmental scan and portfolio analysis. I'll get into and you've seen this framework before, I believe we shared this, but RAND generated a conceptual framework for the federal health services research and primary care research enterprise. And they cataloged the research across the federal HHS and the VA and found 93,000 projects, 92% of which were grants, 8% of contracts. And then RAND collected and derived these key indicators needed to assess the breadth and scope of federal HSR and PCR. And really, they used a machine learning approach to identify these projects. There was some validation that occurred throughout. But really, this approach in and of itself, it was a novel use of machine learning applied to research that has its own limitations and opportunities. But really, given the scope and budget, this was the only way to accomplish this task. Next slide, please. This will give you a picture of what the research domain framework was. There were inputs to healthcare, including organizations of care, financing of care, social factors, personal preference and behaviors, and then outputs, quality of care, access to care, cost and utilization and equity, and then kind of spanning all of this, they categorize things by research methods and tools. And certain projects could be in multiple categories. And they were also able to drill down into some special topics: patient safety, health and well-being, prevention, pediatrics, and aging. Next slide, please. Next slide, please. So on to the findings. Again, I think we'll all be excited to hear that, HSR has made a difference in patient lives, and it's vital for improving the quality, safety, and value for all healthcare Americans. I think we can all agree that 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 is true and a good finding. It also found that the research done across HHS is mostly complementary and not duplicative. And that's a really key finding because that's kind of the impetus for this report to begin with. And so it also found that AHRQ has a unique role, again, focused on systems-based outcomes and approaches to improvement across US healthcare settings and populations. And we're the only agency with a statutory mandate to generate HSR. Other agencies do generate HSR and PCR as part of their missions and operational needs based on particular settings and populations, research objectives and audience, but we're the only agency with a mandate to do this. Next slide, please. And as I mentioned, the study pointed out that agencies are sensitive to avoiding duplication and the appearance of duplication, although sometimes it appears that way. And once they are identified, we are adept at coordinating funding on a particular topic, but the process of discovering the overlap is more sporadic or accidental in nature. And so it would be helpful if we had better data to help kind of develop some systematic processes to help identify these potential overlaps in advance. Additionally, new types of HSR could help improve impact based on existing frameworks of research impact as well as discussions with study participants. The study identified 6 categories of impact of federally funded HSR and PCR, ranging from impacts on scientific and professional knowledge to changes in the healthcare system and services and policies and patient and societal outcomes. And the impacts across a range of categories is unlikely to be generated by a single research project. And really, I think this is a really key finding, that it's not only are we not duplicative, but it's actually the nature of having multiple projects that really leads to an accumulation across these agency portfolios that really does lead to impact across HSR and PCR. Again, and the study also found that HHS could explore more innovative methods of funding, including approaches such as learning healthcare system models and finding new approaches to dissemination. Similar to HSR, primary care research, it was found to be critical, underfunded, and has a significant impact on patient lives. Again, I think this is something everyone in this group probably all agrees with. And again, PCR has been cumulative across agency portfolios. And again, PCR work is mostly complementary and not duplicative. And with each optive playing unique roles in PCR funding. And again, we're the only agency statutorily mandated to fund PCR, but currently we do not receive set aside appropriations to do so. Next slide, please. Cross-agency coordination of PCR, in particular to prioritize research topics, could add value and might lead to increased impact. Again, same thing, similar to what we heard for HSR as well. And getting more data systems would really help us do this more effectively. And again, there might be novel forms of funding PCR work that could improve PCR's impact. Next slide, please. Moving on to the scan results, you can just see there are 6 agencies that do most of the HSR and PCR across the department. NIH is clearly the behemoth. The VA and AHRQ do a bunch of work, and then there's a huge drop off. And the highlighted examples here are just confirming what we would intuitively know to be true. The scan confirmed the focus areas across these agencies, but with the scan alone, if you just looked at this, you might think that there is overlap occurring. And what it shows us is that it's really not until you drill down into more of the specific projects that you really learn that it's complementary research and not duplicative research. Next slide, please. And again, this is another slide confirming what we know to be true, and it shows the more drilling down into more specific categories of aging, patient safety, pediatrics, and prevention. And again, it's confirming what we already think. AHRQ houses the majority of patient safety work. CMS focuses on aging, and CDC houses most of the prevention work. Next slide, please. I'm not going to go into all the range of gaps that were identified. You can read that in the report, but the gaps that were raised were ones that were raised by multiple study participants. And really, they're very similar for HSR and PCR and just kind of differs by setting. And none of the gaps are truly novel. Others have written about it before, but what they're really emphasizing is that there's a lot more research that needs to be done in these areas. Okay, next slide, please. Next slide, please. And now we're moving on to what we want to focus most of our conversation on today. And really, these are the key study recommendations. And the first one is improving cross-agency prioritization and the coordination process. We should initiate a strategic planning process across federal agencies to prioritize HSR and PCR investments, improve HHS data systems to allow for the identification of HSR and PCR activities, especially as it relates to intramural and contract activities. Just the data that exists there is not as robust as some of the grant work. We should establish a review process to proactively identify these areas of potential overlap. And then provide funding to allow proactive HSR and coordination. Clearly, this would take funding in order to do. And it also recommends that AHRQ should be an independent agency within HHS. It also recommends AHRQ should serve as a hub for the federal HSR. And it says that we should identify, or a hub should be identified for the federal coordination of primary care research. It could be AHRQ, but it could be somebody else. Next slide, please. And here's the key recommendation that we think could really use NAC member input today. And it's really, and again, I think we started talking about this in the earlier session this morning, but improving the relevance and timeliness of research. It was recommended that we create funding mechanisms that support more rapid, engaged research approaches, such as embedded researchers or the learning healthcare system models. Expand funding to refine mixed qualitative and quantitative research methods suited to generating evidence on the implementation of change and complex health systems, and potentially creating funding mechanisms that support innovative, high-risk, high-reward research. And then next slide, please. And the third recommendation is to disseminate and communicate results that are actionable and findable. Train and assist researchers in effectively communicating results in formats that can readily be used by healthcare delivery stakeholders. Again, we've heard this over and over again, not only in this study, but in some of the roundtables we've done, as well as our stakeholder outreach as well. Require researchers to consider implementation issues early on in the study and explicitly apply theories of change to help connect disparate results. And third, expand funding for the synthesis of evidence across studies. Next slide, Jen. Next slide, please. Moving on to next steps, just to let you know kind of where we've been. Our AHRQ director, Mr. Khanna, briefed HHS leadership on this report in March. The report was then shared with our sister agencies, and we held a debrief with them in April. Our report is posted on our website, and we've done a number of dissemination efforts to help get that out. You've seen some of the blogs that Mr. Khanna has written. And as I said, the report is there. We're also planning a session for the fall part of Academy Health to focus on some of these study recommendations. And then in the future, we're going to be convening a meeting with our sister agencies to kind of begin the process of identifying some of these topics to help with the coordination and prioritization of HSR. And then with that, next slide, please, Jen. I'm going to turn this back over to my colleague, Dr. David Myers, to help us recenter us on this recommendation number 2. Next slide, please, Jen. And he's going to help moderate this discussion here. Thanks so much.
Thanks so much, Jamie. And I hope everybody on the NAC recognizes the incredible contributions and the amount of work and thinking and leadership that Jamie has put in over the last 2 years to understand what Congress asked, to make this happen, to bring it through to such a great product, and now be leading us into what to do next. So in thinking about how we would involve the NAC in this, we realized that recommendation 1 has a lot of work for AHRQ to do, but you sort of have to be inside the ballpark to understand how to coordinate federal things. And that's not what the NAC brings to AHRQ. We turn to you to help us think about how the research community, how the health services deliverers, payers, patients think about AHRQ and what we could do. So we wanted to focus you on this question and the study recommendation of striving to improve both the relevance and the timeliness of both health services research and primary care research. And you saw, and these are again, the 3 areas specifically that are called out. You can read more details in the report if you like. Next slide, please. And then Jamie said, so here are some questions for you first. So what are your ideas about how AHRQ could think about our funding processes to speed the time from the idea that an area should be worked on to when we fund it? Or from the time that a researcher thinks that they have an idea till they get the funding? Are there ideas you've heard from other agencies, from foundations or around the world of new funding mechanisms that we could try to implement that would increase the relevance of our research findings? Are there ideas for methods that we need to invest in to help move forward implementation in complex healthcare systems and across a full healthcare delivery ecosystem? You saw that final recommendation. Do you think we should be supporting innovative high-risk, high-reward research? And if so, how would we do that? And then recognizing the time we're in right now, how can our research funding be used to stimulate progress on important questions such as disparities in healthcare and healthcare delivery? Jamie then challenged me when I asked these ideas. She said, well, could you give me some ideas of what this could look like? And so I'm going to give you a few ideas, not that you should stick with these, but just to get the juices flowing. So next slide, please. So what if we revised our grant review process at AHRQ such that our reviewers only identified the top 5% of meritorious applications and then had a second batch that they didn't rank, but said, this is the next 25% of strong applications. And AHRQ would then go ahead and immediately fund the top 5% and have a lottery among the next 25% of the remaining funds. And you say, well, why would you ever do this? We believe that this could reduce the burden on reviewers, therefore speeding up the review process, but also importantly, potentially decrease the time not only needed for the review, but decrease the biases built into the system that people who have standard ideas that reviewers understand and are in places that people know and therefore have confidence that get that few extra points, and that the ranking might not be actually showing us innovative thinking and new people, and this may be a way of decreasing bias in the review system. Next slide. Or what about creating large program grants? And program grants would be where AHRQ would identify a set of high priority national healthcare delivery challenges and offer much larger grants than we typically does, maybe $10 million a year to address them. And applications would propose an approach and a set of measurable outcomes that they would work on and milestones to achieving them. And that they could then use the money in whatever they want, way they needed, multiple projects integrating over time, changing and developing as new knowledge and experience emerge. And potentially, after 5 years, they could be reviewed to see if the team had done what they had set out to do and then funded for another 5 years. So this could be an example of a high risk, high reward, potentially increasing relevance and dealing with the complexity of healthcare systems. But we have to recognize if we did that, that would take a large amount of money to a fewer number of people. And where's the balance there? One more idea to think about. Next slide, please. What about if and this is a much simpler one, if on all our research grants, or at least our large ones, we required a health delivery system partner, that the researcher would bring a letter of support from the partner, committing the partner to use the results of the project to improve quality, safety, and value if the work is successful. Would this increase the relevance of our proposals and increase the speed of the findings be adopted into practice? So those are just whiteboarding up ideas. And we would now, next slide, turning this over to Tina for you all to just think creatively and share with us, starting now, but continue over the next few months. Next slide, please. To answer these questions. What are your ideas? What can you bring to us creatively to challenge us to move recommendation 2 about increasing the relevance and timeliness of our research? Turn it over to you, Tina. Thanks.
Great, thank you. This was some really important information produced in this report, and I would like to ask all panelists to please prepare your questions, and again, use the chat box to let us know if you have a question coming in. I think it's important that to highlight that, you know, what the report highlighted was that there's not a lot of duplication across agencies, right? AHRQ really has an independent viewpoint on a lot of these issues. So it's important that, you know, we really highlight that information and let people know that AHRQ does have this unique presence and an ability to advance a particular area of research. Okay, here come the questions. And so I do want to, you know, really, again, call out to NAC members to help disseminate this information. You know, AHRQ really has a unique presence, and we need to let people know that so that we can continue to have these opportunities to expand the research and to really identify which areas there are that are most of interest to the community. Okay, we're going to go to Edmondo Robinson has the first question, please.
Thanks, Tina. So one, I had to respond to the list that that they put out in terms of, I like the third option in terms of, you know, finding a healthcare delivery partner as part of the grant process. I would push that a little further, and I would actually encourage healthcare delivery consortium. So I would actually, as opposed to one health system, because you've seen one health system, you've seen one health system. So you kind of, if you could have a collection of them that all agree that we are going to go on this, right? Someone mentioned Project Red earlier, because it gives me that idea, right? So that I would push that angle a little bit more. For this 1, 2, 3, 4th bullet here, in terms of innovative, high risk, high reward research, one angle you could take, it's just an idea, is maybe there's some high risk, high reward research techniques that we actually might want to think about. The reason why I'm thinking of this idea is because Jamie mentioned that RAND used machine learning to scan through those 93,000, you know, examples. And so thinking about ML and AI and how that technique could actually further the underlying goals that AHRQ is trying to accomplish. And actually, I'd mix it with the next bullet, because part of what we need to understand about ML and AI is how it can either improve or exacerbate bias. And so that to me, that's a really important angle there. So that's one way you potentially could really push these more of this high risk, high reward approaches. That's what I was thinking.
Great, thanks for that comment. And I just want to kind of build on that a bit. I wonder if there's opportunities also in that high risk, high reward area where you can think of, you know, we have so many young, brilliant scientists coming out into the field. They think differently, right? They think outside of the box. How do we make these opportunities beyond a K award? I mean, are there smaller opportunities that they can help engage and really leverage some of their new and exciting techniques that they're learning and bring that to AHRQ? I think could be a lot of opportunities there to think about. Moving on, next we have a question from Peter.
Yeah, so I'll just build on Armando's comment too. I think, you know, another way to approach this is not per se necessarily a requirement across the board, but you know, really making the expectation and the indication of a strong health system or health systems partners as part of a proposal a really key element of the score, and making that really just something that, you know, if you don't do that, there may still be worthwhile science. You could overcome it, but you're going to get a lot more. You're going to be a lot more likely to be funded if, in fact, you've tied the work you're doing to something that will, in fact, be implemented and more applied. The corollary to that, I would argue, would be that, and I totally appreciate the challenging balance of the limited budget you have and the idea for these large program grants versus more smaller grants. I'll just make an argument, I think, for more smaller grants in one respect. If you're talking about the connection to health systems, and we want to encourage the development of learning health systems. We want to encourage health systems in their investments that they're already making that in toto dwarf the budget that AHRQ has, to say, how do we in fact take those investments that these health systems are making and use the funding, really synergize and accelerate the work that they're already doing in the right direction by using AHRQ's resources to say, you know, if you really focus in on the implementation science and the creation of learning health systems and doing this kind of health services research, then we're going to have small grants for you that are perhaps you know, a lower bar, a little easier to get. We're going to have more of them. We're going to do them in a more rapid cycle fashion. And there will now be an encouragement to actually pursue this, because usually for at least the larger health systems, the amount of the award is perhaps important, but the actual earning of the award in collaboration with the health system research partners is the more important thing. And so I wonder if there isn't a strategy here that we actually make it more part of the culture for our health systems to say, you know what, we want to actually invest in a line of work that is actually going to accelerate the health services research learning health system activities and pursue more rapid cycle, perhaps smaller AHRQ grants in order to take what we're already investing in and then apply some rigor to studying and disseminating the information.
Thank you, Peter. Some great thoughts there. Something for us all to think about. Gregory, did you have some comments to add to our conversation?
Yes, I do. Thank you very much. Very quickly, one, I think these questions are kind of hard to respond to as a NAC member, but also as a person who's had a lot of funding from AHRQ since back in 2007. So over 12 years of funding from AHRQ pretty continuously, coming up through the K-award mechanism and then other AHRQ series awards since then. And the reason they're hard is because I think AHRQ does these things very well already. So thinking out of the box on these questions is hard because you really are thinking out of the box in some of the new protocols and the new things that you're sending out, the new R1s, and in response to COVID, you're very action oriented when things happen. So I think it's hard to sort of advise you on these things because you're already good at it. But with that in mind, one of the things that I think about when I think of health system partners is I also think about vendors. And not just health systems, but the vendors that are within them and the priorities that vendors have in their development and how new young scientists develop programs of research that are of interest to vendors and how those can be absorbed into STTRs and SBIRs is really important, and how that process happens. I think AHRQ has an opportunity there. And then the last thing is the sustainability of programmatic grants. I've had the pleasure of being involved in a programmatic national study from CMS for about over 8 years now. And it's a big project that is ending at the end of this year. And we've been in the same nursing homes for over 8 years. And we've instituted huge changes and had amazing outcomes. But now that program evaluation is ending, and creating models of sustainability around research that lasts that long and that have that kind of impact are so important for the systems that take on that challenge. And I think that from the standpoint of implementing those, they're very important. But we also have to think on the back end of how sustainability is going to happen and how we can help these systems move, keep moving in the forward direction and not go back where they were. I'm going to stop there. Thank you.
Thanks, Gregory. Some great comments there. I think it's, you know, all of you are giving us a lot to think about. Patrick Romano has a comment.
Yes, hello. Yeah, a couple of quick things. So one is, you know, you folks threw out 3 interesting ideas. And I'll say right off the bat, I don't like the first idea for what that's worth. I can't tell you how discouraging it is for investigators, particularly for junior investigators, to come in at the 6th percentile or the 7th percentile and then not to get funding because they get put into some kind of a lottery or something where they're the same as somebody who's at the 20th or 24th percentile. So I think it's okay to reach down a little bit, you know, based on AHRQ priorities, based on HHS priorities, policy priorities. But the idea of a lottery really sort of just, I think, would leave a bad taste for a lot of people. The second idea, I would be cautious about this idea of program project grants. I know it works for NIH, but I think it in some ways works against the desire to really have as diverse a set of grantees as possible and to reach out and to be able to develop relationships with organizations that aren't traditional large research organizations. So this would lead, you know, probably to a concentration of more funds at fewer organizations that might actually in some ways be less innovative. So, so I think that you've heard from a number of us a lot of interest in the third idea. And I'll just second what others have said about the idea of a consortia. I'm reminded about the practice-based research networks. I know Dr. Myers and others have lots of experience. We should have practice-based research networks for health systems research. And I think, you know, the kind of consortia that we've been talking about, or networks of health systems, is the kind of laboratory that we need for carrying out this kind of research. And I would just point out, I think there's an existing AHRQ mechanism through the Action Network, where you've actually already developed some of these partnerships that bring together research organizations together with health systems. And so that might be one mechanism to further promote this kind of rapid cycle research. I'd also encourage you to consider, you know, perhaps using broader RFAs. I know it's a very tedious and time-consuming process to issue a separate RFA or funding opportunity announcement for every specific area of work. But I wonder if there's a mechanism to issue broader RFAs and that really bring in a lot of applications, and then to sort of reallocate those applications after they come in according to program priorities, so that you would perhaps be more flexible in your ability to respond quickly. I mean, if you have 100 applications that are already on the shelf that have been scored, and then you identify that you have a new priority area, then you could reach into that pool potentially. You might ask the submitters to update something, but it would potentially give you a mechanism to respond more quickly rather than having to write a separate funding opportunity announcement in every little area that, that you might be interested in. So just a few ideas. Thank you.
Thanks, Patrick. A lot of things to think about for funding and how we can, you know, improve the process, make it quicker, make it more timely. Next comment is from Melinda.
Hello. I guess I thought that all of the ideas had some merit, so I want to commend the group for coming up with them and for proposing them and for them being bold. I guess I would say that I would hope that the choice of which to do could be evidence-based. and that there could be some consideration about different mechanisms for different types of research. If you want implementation research or patient safety research, then you might need a different mechanism than if you want health services research or payment research, or the type of modeling research that was discussed this morning. And if you sort of looked at what works by types of area, what were your best grants and how could you have gotten there faster? I'm hoping it would give you some insights, in particular on the issue of the younger investigators and the awards. It could be that what you discover is that for young investigators, as long as they do score under the 25th percentile, they eventually get funded. And you could sort of cut through those rounds of revision and instead offer them mentoring or coaching of some type in an earlier award. So it may be true also of particularly experienced investigators, that they often, you know, just get funded, but it takes them more than once, and you could accelerate your time frame by having a different type of mechanism. And my final thought about the lottery is that I agree that it could feel disheartening, but if you could have a special way to reward innovative thinkers or young investigators, it might be a great mechanism. So instead of saying there'd be a lottery for everyone up to the top quartile, you could have your study sections nominate young investigators or particularly innovative concepts to go into a pool for a lottery. And that might get around what I think is a true flaw of the process, which is that it doesn't necessarily reward innovation. And I commend you for trying to think of creative ways for trying to get beyond that known flaw. I also know that because AHRQ funding lines go up and down, it can sometimes be difficult to get really strong study section reviewers because they feel disheartened that they will see so many good grants that can't get funded. And so maybe this would also build desire for people to serve on these study sections.
Thanks, Melinda. A lot of great comments. I really like your idea of potentially like assigning a mentor to some of these junior investigator awards that score high but don't quite make the cut. So a lot of things to think about there. I have a question or comment that I'm going to, that I inserted. And I want to make a comment to the last point here, which is, you know, how can AHRQ build research funding to think about systematic biases in the healthcare delivery systems? And, you know, when we look during this time of national unrest, there's been a lot of movement to try and address systematic bias across all industries, across, you know, you have the Academy Awards, you have newscasts, you have everything. And one thing I'm wondering that could be a potential way for AHRQ to address this is really requiring a section in a grant that is going to address systematic bias for all research proposals. It could be a requirement that, you know, you want people really to think about this, and they're going to have to comment on it and really build upon how is their research going to address systematic biases in the healthcare delivery system or in health outcomes. You can also think about, you know, requiring that when these grants come in, they have to have a diversity of investigators on the team. You know, maybe you can have extra points scored for, you know, really promoting some diverse junior investigators, diverse faculty, et cetera. So I think there's a lot of ways to think about how AHRQ can really promote an unbiased or address some of these systematic biases. And those were just a few comments that I had for that point. Okay, next on our list for comments is Yan-Ling, please.
Thank you, Tina. I really like this high risk and high reward funding mechanism. And NSF have used this for many years, and I've been a research, academic research arena, and that's how we get used to NSF funding opportunities. And I think that AHRQ could use this high risk, high reward funding opportunity to address the emergent issues in healthcare, and such as the COVID-19 infection right now, and also healthcare disparity. And the nature of this type of research questions typically probably require shorter research time, and therefore less funding, money required. And so I think that this, emergent research issue could come up from either from top down or bottom up, and from the community, and the second, I think that should make a criteria, number one, for this selection of high risk and high reward. And the second criteria, I think, it should have, related to the way how researchers, the proposal address rapid dissemination. I think that should make a criteria in the proposal reviews. And in order to, for rapid dissemination, they should have a plans, how they gonna do it, how they work stakeholders, and that should be a things to review for the proposal. And then number three, I think that should building in the learning health system model into this type of proposal that could involve with the stakeholders, including consumer patients, that into like a partnership to learn from the system, to come up with ideas to refit into the system. So that's my comment.
Thank you. We have a couple more comments to get to. You guys all have such great ideas. Thank you for bringing these forward. Next, we're going to go to Christine.
Thank you. Very quickly, I'll send my written comments and questions, but one area that hasn't been addressed that I think would be innovative and potentially important if AHRQ could address it is doing some research on, I'm going to say, healthcare leadership, healthcare management theories. We have a growing number of clinicians who are assuming management and leadership roles, and they in fact are controlling the purse strings of organizations, and yet there's very little known about how those individuals function and how they network and how they successfully influence the quality and safety in their organization. So I think there's a space there to look at healthcare leaders, and it might fall within that learning health system umbrella, but I think leadership in particular is an area that needs to be looked at and studied, and I think AHRQ is a perfect place because we could in fact tie some of that to how organizations actually perform on quality and safety work. The other thing that I think would be interesting in that same space is to change up, if you can, who's on the study sections, who are the reviewers. We have long-standing, well-versed researchers on a lot of study panels. We have stakeholder representatives. They often are not system leaders. And I think mixing it up a little bit, if you really want to look at how healthcare delivery is changing, we need to get review panels that reflect the organizations that are going to be doing the work versus just a letter of support. I can get a letter of support any day of the week, and they have no idea what I'm going to do, or that I'm going to be asking them to do something different in terms of changing organizational dynamics. I think, and it might be with some of those high dollar ideas, but I think putting our caps on, and I need to do more around this, getting health system leaders invested in the research process personally, individually, even though they're not researchers, is going to be critical to moving this agenda forward. Thank you.
Thanks, Christine. I think those are some great points also. We have another comment coming in from Gretchen.
Hi, thanks. My comment references back to one that Gregory Alexander made about this is a hard question to answer. And I'm going to paraphrase you, Greg, but it's like, because you're in the box of being a researcher or grantee. So it struck me that I'm one of those who's outside the box. And it's difficult for me to answer it because it's would be helpful to have an objective assessment of the strengths and weaknesses and kind of a baseline of what your current funding challenges are. So one of my principles has always been to be reluctant to recommend solutions for changes without first getting some kind of an agreed upon problem statement or a common framework, even for the experts who are already inside the box. Thanks.
Thank you. So I think we've gone through most of our questions. Jamie and David, would you like to add any additional comments before we, well, actually first, Gopal, I would like to know, do you have any comments to add? We've had a lot of great discussion points. Perhaps you have something you want to add? He might be muted.
He's unmuting.
Okay. Yeah. So Jamie and David, do you want to follow up on? Oh, there he is. Hi, Gopal.
I'm here. Thank you, Tina. I just want to say that this has been an extremely rich conversation, and there's so much for us to absorb. We have picked up a lot of information. The three things I want to quickly point out. One is that Secretary Azar has really taken a vast and large approach in terms of whole of department approach as we respond to the COVID-19 crisis. I see COVID-19 as a game changer from the point of view, apart from the fact that it has a huge human toll and resource impact as a nation for all of us, but it has opened our eyes as a member of the Secretary's team to identify what are the gaps. So one of the things my colleagues and team has done marvelously well at AHRQ is looking at what are the gaps where AHRQ's core competencies can be leveraged to create a much bigger, larger impact. So we've taken identifying the gap strategy. So one of the things I've heard today is talk about the gaps. However, as you have all pointed out again and again, there's a huge growing gap between the gaps in terms of the need for better improved delivery system, more effective and more efficient and safer delivery systems versus the resources we have. And again, I'll come back and say, maybe today may not be enough time, but what is the amplification strategy? How can NAC help us amplify that message? Now, today the Secretary is at Rush, and I'm glad that Omar Latif got a chance to meet him and give him a tour. So those kind of opportunities are great because the Secretary Azar is going and literally every week visiting states and delivery systems. So there might be opportunities where, again, given your background expertise to amplify AHRQ's message. Finally, I would like to say thank you, Tina, for leading this effort, for chairing NAC. And to all my colleagues, David and Bob and Jamie, for the marvelous work they've done, as well as there seems to be some kind of a breakout over here, all as well. But thank them and the entire AHRQ staff for doing a great job. That's all I wanted to say. So thank you once again. I need to, in a moment, run for another call. But thank you, NAC members. I appreciate it.
Thank you, Gopal. We are a bit ahead of schedule. If anyone has any additional comments, please post those. At this time, we have no public comments. First I would like to thank, before Gopal leaves, I would really like to thank Gopal, David Myers, Bob, and Jamie for their presentations. There was so much information shared today, and the enthusiasm was just like over the top. So it's really exciting to see how all of this great information coming together and just the enthusiasm that the team has. I'd like to thank the AHRQ staff and those who joined the meeting via the Zoom webinar. Please mark your calendars. The next NAC meeting will be November 10th. This will be another virtual meeting. I know it's so, there's pluses and minuses about this virtual meeting. I know we all miss the dinners and the conversations we have offline. For me, that's the biggest downfall of the virtual meeting. But on the other hand, we get to spend more time at home with our family and loved ones. So, there's pluses and minuses. So the meeting November 10th will be virtual. I think we have just one or two more questions that came in. Gregory had one more question. Gregory, you want to help us wrap up this meeting and throw us a question or comment?
Sure. I just have a quick comment. and I think I commented this, maybe, I don't know if I commented it to the whole thing, people, but my concern for such a big change in the criteria for what 25% or 5% is just early input by all the stakeholders that are involved with AHRQ for that kind of change would be really critical so that you make informed decisions that are supported by everyone. And then just transparency of that process and the results of those ideas transmitted and disseminated widely to those stakeholders with made decisions based on that input would really be important to keep people really excited about AHRQ and excited about what's happening and not frustrated with the process, because that's a fairly major change and one that people might have concerns about as they think about it more. Thank you.
Great. Thank you, Gregory. So with that, we have no more comments for the meeting today. I would like to
Tina,
adjourn.
I'm sorry.
Oh, yes, we have another comment. Yes, please.
Sorry, this is David, everyone. I wanted to let you know that Jamie asked me to come up with ideas that would get people out of their boxes. So I think we were successful in doing that. The 525 was not something we are getting ready to move on. It was to try to free everybody on the NAC up to think about ideas that might seem radical. And so Gregory, I want to make sure you know, before we would do anything that radical, we absolutely would go through the process, as Gretchen reminded us, of what's the problem we're addressing, what do we know about it, and engaging our stakeholders to make sure it's leading to the goals that we want, and then to test if we did. But I encourage you all to think about, what have you been hearing from colleagues in Europe or in Asia or from foundations that you found really exciting? Or the ones that they tried, you're like, don't do that. We need to hear from you so that we can stay innovative and as I hope, people thinking of us as an agency that's doing good work and engaging the community in good ways. So thank you all for thinking outside of the box, inside the box with us, changing the walls of the box. Let's keep doing that.
Yeah, no, and I'll just want to emphasize what David was saying is that this is the first of many more conversations that we hope to have on this topic. And so, as I say, we're going to talk about this a little bit more at Academy Health, but in other mechanisms as well. So please keep your ideas coming as you have them, or please call us, pick up the phone, or email us. We're really excited to hear more about this.
Yeah, thank you. And I also think it's a good opportunity. I mean, we have a lot of conversations going on in the chat and other ways. Stay connected with your NAC members. I think it's a great opportunity to further discuss these ideas, engage the people from AHRQ, and really think about how we can get that information out there. We have great perspectives. I think that maybe, some of the NAC members can get together and pull those ideas together in a more formal way and disseminate that information. I think there's a lot of opportunities to engage and continue these conversations before November, right? We want to continue these conversations. And I think it's really important that, we can move this beyond just a quarterly meeting to keep our NAC members engaged with what's going on. Gopal has many blogs that he's posting all the time. I really encourage you guys to look at those, share them, retweet them, and just make sure that we're sharing that information. With that, I think, well, let's see, Yang Li has one more comment before we adjourn.
Yeah, just very quick. This COVID-19 pandemic, it really exposed our health system, what is lacking, what we're doing well, what we're not doing well. There's so many gaps, in terms of infection and public health system. So I think this rapid high risk and high reward funding opportunity should really focus on that, how we can address this, because the next wave is coming. So I would like to see we get some really gaps, research and data and evidence out for the practice and safety.
Yeah, and I think there's, you know, this is a good opportunity to, you know, pitch your ideas to AHRQ. You know, what do you think about for future topics? You know, what are things that we can think about to help AHRQ think outside of the box for these funding opportunities for rapid dissemination, evidence generation, et cetera. So I think that, you know, we should continue these conversations offline and engage AHRQ. And so with that, it is almost the top of the hour, so I would like to adjourn the meeting. I will ask for a motion, please, to adjourn the meeting. And a second.
Second.
Thank you all so much. So with that, thank you for your time. I think the virtual meeting is working out well. We're all getting used to it. So everyone have a lovely afternoon, and hopefully we'll hear from you before November. So let's keep those conversations going. Thank you all so much.
Thanks all.
Thank you all. Bye.
Bye-bye.